Thank you all for coming to kick off the Grand Round season for 2025, 2026. To those online and those that are still making their way, I am absolutely delighted to introduce our speaker for the day, Dr. Emelia Benjamin. She's visiting us from Boston University. I first met her in August of 2004 when I was an intern at Boston University on the CCU service.
Talking to me.
Yeah, she has mentored me and others over the years. She earned an undergraduate degree at Harvard University, went off to Case Western Medical Center where she earned an MD. Then she came back to Boston University and Boston City Hospital where she was a resident and she did a fellowship there. She went on to become a Framingham Fellow, earned a master's degree from the Harvard School of Public Health in epidemiology. And over time, she has been a leader in the field of cardiovascular epidemiology with a focus in atrial fibrillation. She has in excess of 800 peer-reviewed articles in top journals such as the New England Journal of Medicine, the Journal of the American Medical Association, Nature Medicine, to mention but a few. She has been cited more than 330,000 times. She's in the top 100 authors to be cited nationally. She has led numerous efforts across the globe and the country. And at BU, she is the interim dean for faculty development. She has a passion for mentoring, which is how I met her. And in this practice, she also mentored Manju and Reno Orlandi, who was a fellow early on in her career for her. She has a strong commitment to mentoring people and teaching and academic research. She has had numerous awards, including an honorary Doctor of Medical Science degree from Aalborg University in Denmark. She has been an AHA Distinguished Scientist Award. If I were to go on and on about her CV, I think she would not have a chance to talk about her at Grand Rounds talks. So we are absolutely delighted to have you here at the Minneapolis Heart Institute to talk about Lifecourse approaches to atrial fibrillation, focus on prevention and social drivers. Thank you.
Really an honor to be here. Thank you so much. Now, there it is. Great. So these are my disclosures, and probably my more important disclosures is you don't get 800 publications if you don't talk lots of people into letting you be their mentor or their colleague. Shown in the stars are people that I've managed to write research grants with, and really am truly honored. And one of the most joyous parts of being an academic is seeing how people, when you work with them as interns and residents, how they become leaders like Edwin. It just is really is a joy. Thank you. Thank you so much for inviting me. It also gets you invited to really cool places, by the way. So we had a delightful dinner last night. So my learning objectives is I really want us to think deeply about practicing primary and secondary prevention of atrial fibrillation. We need to get to the place that we've been at for 3 decades with coronary heart disease. Because atrial fibrillation is a preventable or postponable disease. And then we need to think also about how do we understand data linking social drivers of health to atrial fibrillation, and then think about the critical research priorities to improve outcomes for everybody across the population. So I'm going to talk briefly about the background where most of my research has been defining the prevalence, incidence, and outcomes of atrial fibrillation. So this is a slide with one of my mentees, Dr. Schnabel, where we looked at the incidence of atrial fibrillation at the Framingham Heart Study over 5 decades with routine surveillance. And so it's not biased by changes in ICD codes, et cetera. And you can appreciate that the incidence has gone up a little bit, but what's really striking is the prevalence has gone up more than 4-fold. And part of that is because of the aging of the population, but we accounted for, these are age-adjusted rates shown on the vertical axis. We also know that people are living longer with heart disease and atrial fibrillation, such that atrial fibrillation is actually becoming more common than many of the other diagnoses, such as coronary heart disease or heart failure. We can also predict atrial fibrillation. Probably people don't remember back to the last crash back in 2008, but they had a whole series of challenge grants. So I called up my chief competitor, Dr. Alvaro Alonso, who's a wonderful colleague, and said, look, we have a Framingham risk prediction instrument. We have an ERIC risk. Let's just do one. Let's get together. Let's do one together. And so we gathered cohort studies in the United States and then replicated them in Europe and came up with the real seminal risk factors for atrial fibrillation. You might note that lipids are not on here, and that's a whole other talk, but even when you look at Mendelian randomization, lipids are not as important for atrial fibrillation onset. The advantage of a risk prediction instrument, and this is the most widely replicated one, is that an individual can look at it much like the coronary heart disease prediction or the pooled cohort equation or the PREVENT equation. You can look at it and you can say, well, where am I? Where would I be if I had optimal risk factors, which would be 6.8% at the age of 68? And where would I be if I had lots of risk factors, like being overweight, like having mildly elevated systolic blood pressure, et cetera? So it's a risk communication instrument. We also know that there is both a genetic and an environmental component, environmental meaning risk factor component to atrial fibrillation. So shown in the there we go. Showing up here are people at low polygenic risk. This would be intermediate polygenic risk and high polygenic risk panels. And the vertical axis is lifetime risk. And the saturated, more or less saturated colors are clinical risk. So somebody at low clinical risk and low polygenic risk has a lifetime risk of atrial fibrillation, about 22%. On the other hand, somebody who has a high polygenic risk and a high clinical risk has a lifetime risk of atrial fibrillation of 48%. So, 1 and 2. So we could use that both for motivating people potentially to alter their risk factors, but also if we wanted to do prevention trials, we would focus on those at highest risk. We also know that there are serious complications after atrial fibrillation. This is a study that I'm doing with my colleague in Aalborg University and somebody that I mentor, Nicholas Winter. And again, cumulative incidence of atrial fibrillation shown over age. You can appreciate after the onset of a diagnosis of atrial fibrillation, about 2% of people go on to have systemic emboli, 10% have MI, about 20% have any type of stroke, 11% are ischemic stroke. Look at heart failure, 42%, and yet we don't have the randomized controlled data to prevent the onset of heart failure in people with atrial fibrillation. If I were a trialist, I think that's where we need to go. If you think about, there aren't a lot of conditions where, basically half the people will go on to get another condition. We really need to develop an evidence base to prevent that onset. In work that I don't have time to show you, we know that it's associated, regardless of the timing, which came first, the AFib or the heart failure is associated with worse outcomes. Which really brings us, I was part of the atrial fibrillation guidelines published in 2023. And much like the heart failure guidelines, we understand that atrial fibrillation is a life course phenomena. It's not like you wake up one day with nothing and then you have atrial fibrillation detected on your smartwatch. Basically, there are people that are at risk for atrial fibrillation, which is stage 1, people that have pre-AF, which is stage 2, and those are people who have structural or electrical findings that predispose them to atrial fibrillation, people who have atrial fibrillation that we have not assumed is going to be permanent, which is stage 4, and within stage 3, there's paroxysmal, persistent, long-standing, and successful ablation, et cetera. So these are transitions. What I want to draw your attention to is management-wise, at every single phase, we need to be treating modifiable risk factors. So how does that relate to the heart failure, which has a very, very similar, and this is a beautiful image that I had nothing to do with. And so I want you to see that people in blue have heart failure, and I apologize for people who are blue-green colorblind. People in blue have heart failure alone, and that's shown up here. Again, the stages of risk: at risk, pre-heart failure, symptomatic heart failure, advanced heart failure. Shown in yellow are people with AFib, at risk, pre-AF, paroxysmal persistent, et cetera, and then permanent AF. And shown in green are people that have both. The critical factor to realize is at every single phase, whether you have heart failure or atrial fibrillation, you need to be doubling down and controlling the other risk factors, partly so you don't go on to develop the contralateral condition. And then when we get to managing both, treating both coexistent heart failure and AFib, you can appreciate that rate control has a very important role to play, rhythm control, and guideline-directed medical and device-based therapies as indicated. So let's focus to the data for the prevention of atrial fibrillation and its complications. And I'm going to focus first on primary and then secondary. So primary prevention is you have a risk factor and you want to prevent the onset of a condition, in this case, atrial fibrillation. So this is the meta-analysis. People with higher BMIs per 5-unit increment of BMI have a 28% higher risk of developing atrial fibrillation, new onset atrial fibrillation. I think this is part of what's driving the atrial fibrillation epidemic, aside from the fact that people are living longer with coronary heart disease, heart failure, et cetera, and so having time for their atria to remodel. We've had a shift in the risk factor burden in the population that's quite dramatic over the last 5 decades. We also know that when we compare people who, from the UK Biobank, the risk of incident atrial fibrillation, individuals who currently smoke have the highest risk of atrial fibrillation. Those who used to smoke but quit have a 13% lower risk. Those who quit smoking during the course of the study of being in the UK Biobank had an 18% lower risk. So this is something that, just like coronary heart disease and heart failure, we need to be focusing on smoking rates. We also know that the atrial fibrillation incidence decreases with intensive blood pressure control. This is data, a post hoc analysis from the randomized controlled SPRINT studies, which looked at atrial fibrillation incidence, people who had intensive blood pressure control and people who had standard blood pressure control. We talked about this blood pressure control at dinner last night that you know, when, this is embarrassing to admit, when I was in my primary care clinic at East Boston Neighborhood Health Center, my attending proudly told me that you treated blood pressure because you took 100 plus the age, and that was the systolic blood pressure you tolerated. And you kind of say that, you think like, my God, was she born in like, 2,000 years ago or something, Anyhow, so we know that we need to be treating blood pressure, and we know from the guidelines that were just published in the last couple of weeks that the goalpost has changed, and it used to be 140, and now it's under 130. And I confess, because I've got a family history of late onset dementia, I'm driving my blood pressure down to less than 120. And my dad and my father-in-law both had atrial fibrillation, so I'm also interested in preventing my atrial fibrillation. And we know that the hazard ratio with intensive blood pressure control less than 120 is 0.74, or a 26% reduction. What about SGLT2 inhibitors? In the next 3 to 5 years, you are going to be seeing, they're going to start putting it in the water. It's like kind of, 2 decades ago, we talked about statins. It's like, fluorinated, water, like, although we're taking that away, we'll probably take this away also. But anyhow, so, SGLT2 inhibitors did not make it into the guidelines because the evidence base is emerging now by people, and you all are very involved with clinical trials and prevention. I think that if we fast forward, that's going to be part of the armamentarium to treat people with atrial fibrillation, partly because, we have such a miserable time trying to get people to lose weight. But this is to prevent the onset of atrial fibrillation. When we look at meta-analyses, randomized controlled trial, people who had diabetes, heart failure, or CKD, we can appreciate that the relative risk of the onset of atrial fibrillation is 0.82 or an 18% reduction. Okay, so what about drinking? This has been like, it's really fun to be in medicine because like things kind of come, they go, a drink a day keeps the doctor away, and I'm like, oh, maybe not so much. I'm in the not so much camp. The risk of atrial fibrillation per 1 drink a day increment in alcohol consumption is 6% higher. And so something to really think about. And so what did the guidelines come down for primary prevention? So I point out this is a class of recommendation 1, so our highest recommendation. The level of evidence was not randomized. It's very hard to randomize people to things like, okay, you smoke, you don't smoke, right? But what we can do from both the observational and some of the secondary data from other studies, is that patients at increased risk of atrial fibrillation should receive comprehensive guideline-directed lifestyle and risk factor management for atrial fibrillation, targeting obesity, physical inactivity, unhealthy alcohol consumption, smoking, diabetes, and hypertension. Secondary prevention, there's more randomized data. One of the first studies that came out was by Prash Sanders groups from Australia. For whatever reason, the Australians are like, decades ahead of us in terms of the prevention of atrial fibrillation, probably in large part because of the Prash Sanders group. And they took people with weight management versus, lifestyle. And those who were randomized to the intervention, and we're not talking like losing a pound or 2, we're talking 10% of total body weight, like real weight reduction, compared to reference or controls, had lower atrial fibrillation symptom burden score. That's what's on the vertical axis. And then they also had fewer episodes of atrial fibrillation, 2.5 less versus no change, and their cumulative duration of atrial fibrillation was dramatically less, 692 minutes less versus having 419 minutes more. So the guideline says, class of recommendation based on randomized data, patients with AFib who are overweight or obese, weight loss is recommended with an ideal target of at least 10% weight loss to reduce AF symptoms, burdened recurrence, and progression to persistent AF. The Active AF study is another study from Australia that randomized people to exercise versus control. Exercise led, and this is arrhythmia-free survival shown on this axis. Exercise led to a decrease in the recurrent atrial fibrillation and improved symptom burden. Atrial fibrillation free at 12 months, the hazard ratio was 0.5. So 20% of the people were AFib free if they were in the control. 40% of the people were AFib free if they were randomized to exercise. So exercise should be part of our armamentarium when we're thinking about secondary prevention of atrial fibrillation. And the guidelines say, class 1 recommendation, level of evidence, randomized in individuals with AFib. And little asterisks, people who don't have their AFib from being elite athletes, which I have to be honest with you, at an urban safety net hospital, haven't been a big problem. But, I'm sure here in the Twin City area, you have people who are elite athletes, who are marathoners, who competitively row, et cetera. I'm not talking about them. I'm talking about the average patient that you see. Moderate to vigorous exercise training to target 210 minutes per week is recommended to reduce AF symptoms and burden and to increase the maintenance of sinus rhythm, increase functional capacity, and improve quality of life. Quitting smoking, for obvious reasons, we don't really have randomized data on. This is a lot of really interesting epidemiology work out of the observational Korean National Health Insurance data. And they had a very clever design where they looked at the total population. This is, insured people. And they looked at people who had their atrial fibrillation diagnosed 2010 to 2016. And they divided them up into people who never smoked, people who smoked but quit before the diagnosis of atrial fibrillation, people who quit after the diagnosis of atrial fibrillation and before their second health exam, after their AFib diagnosis, and people who continued to smoke. And what you can appreciate is when you quit smoking versus you remain smoking, your hazard of developing dementia is 0.83. This is the only dementia slide I have, but I think that we as cardiologists, guess what? They're connected. We know that, and we don't think enough about cognitive health. It's one of the reasons why the American Heart Association, as well as being the American Stroke Association, is really thinking about brain health, because the brain, obviously, if you ask, I think Edwin said this last night at dinner, if you ask most patients, many patients would rather die than have a stroke and live, if it's a very significant disabling stroke. And I think the same thing is true of people with dementia, that they're very, very fearful of dementia. We haven't really thought enough about the importance of controlling atrial fibrillation to prevent dementia onset. So the data, not randomized again, people with a history of atrial fibrillation who smoke cigarettes should be strongly advised to quit smoking, should receive guideline-directed medical therapy for smoking cessation. We know how to get people to quit smoking. Takes average attempt 7 times, but one can do it. And it's going to mitigate the risk of atrial fibrillation, cardiovascular complications, and other adverse outcomes. When we look at, there actually is randomized data for alcohol abstinence. People who, this is the Voskobonic study, it was out of Australia also. And basically, this was published in the New England Journal back around 2020, pre-pandemic, I might add. Probably not a coincidence. Good thing they didn't try to pull it off in the pandemic. And here are people, on the vertical axis is the probability of recurrence of atrial fibrillation. And people who were randomized to abstinence were much more likely to be recurrence-free, 47%, versus those who were the control. This is an open-labeled study at 6 months. That's a big difference, right? And I talked to your group. It's not, the atrial fibrillation group here actually is engaging in secondary prevention, but if you look across the country, that's not happening. And this is an opportunity. So the hazard ratio is 0.55, significantly different. So it's a class of recommendation 1, level of evidence randomized. Patients with AFib seeking a rhythm control strategy should minimize or eliminate alcohol consumption to reduce AF recurrence and burden. We also know from blood pressure lowering treatment trialist collaboration, 22 studies, a 5 millimeter per mercury systolic blood pressure reduction reduced the risk of major cardiovascular events. Patients with AFib, the hazard ratio was 0.91, which was statistically significant. So the class of recommendation was 1. The level of evidence was not randomized because a lot of these were sort of secondary analyses or post hoc analyses. Patients with AFib and hypertension, optimal blood pressure control is recommended to reduce AF recurrence and AF-related cardiovascular events. How are we doing? I think I already mentioned we're doing a kind of lousy job. This is older data, but frankly, I don't think it's really improved with the fragmentation of our health system, that something like 93% of individuals in the Orbit AF study were eligible for other evidence-based therapies. Forget the AFib guidelines. Just if you went by all the other comorbidities, they had a lot of recommendations. And among the eligible, less than half received all their indicated therapies. So we can be doing better is the point. And how do we do better? Class of recommendation 1, level of evidence A, patients with AFib should receive comprehensive care addressing guideline-directed lifestyle and risk factor management, AFib symptoms, risk of stroke, and other associated medical conditions to reduce AF burden, progression, or consequences. And we talked about this. I mean, if you're an electrophysiologist and you need to talk to somebody about their complex ablation, this is, that's going to take your 30 minutes, right? And this is where we really need to be thinking more about team-based care. I hope we have some nurse practitioners in the audience. I think nurse practitioners are going to be absolutely instrumental in advancing the, really making people live longer and healthier when they have atrial fibrillation, and really need to take a page out of the coronary heart disease groups and the heart failure groups where they've had extensive use of nurse practitioners and pharmacists, I might add, I hope there are pharmacists here, to really manage people's comorbidities and make sure we're attending to all the other non-procedure related issues. In terms of having a clinical care pathway, it's randomized, but the level of recommendation is 2A for a variety of reasons. So big, big opportunities, and all of us could be doing better in the secondary prevention. I want to spend the next part of my talk talking about systemic or social determinants of health. And there are fundamental systemic barriers, and I kind of asked at dinner last night, like, I'm not making a political statement here. I'm really talking about what is the data. Okay, just I grew up in a Republican household, and this is not political. I think we need to get back to, we can disagree about the solutions, but we agree about the facts. And I'm going to talk about the facts around this. Anyhow, okay. So one of my favorite radical hotbed of organizations is the American Hospital Association. Not right. I think we can all agree that's not a radical organization. And they point out to us that when we think about people's health, 20% is their health care, 30% is their health behaviors, 10% is their environment, and 40% is socioeconomic factors. And when we go to medical school, we spend 100% of our time thinking about healthcare and not some of these other issues. So let's look at the data for education and income. We can look to our northern neighbors. This is one of my collaborators, Abdul Qadir. I was not involved with this manuscript, but it's a beautiful, beautiful study. And they looked at adverse outcomes by material deprivation of an individual's neighborhood. So a lot of times when we do social studies, we think about what neighborhood do I, what are my, my education, my income, my habits, et cetera. But a lot of information really comes from the social neighborhood and the social fabric. So they looked at the material deprivation of an individual's neighborhood. In the United States, we call this area deprivation index, same data. And they looked at people who were in the fifth most deprived or the worst versus the first quintile. And those in the fifth quintile or the most deprived in a system with universal insurance coverage, right? So not the hodgepodge system we have. They were 3% less likely to be anticoagulated, 20% less likely to receive a cardioversion, 55% less likely to have an ablation. And this has outcomes. This has consequences. This looks at adverse outcomes. Those who were in the most materially deprived neighborhoods had a 16% higher risk of mortality, 16% higher risk of stroke, 16% higher risk of bleeding, and a 14% higher risk of heart failure. So clearly there's something going on with the neighborhoods, even in a system with universal coverage. Much as we talked about in the beginning of this talk about Lifecourse, AFib being a Lifecourse condition, some investigators in Italy did this very, very clever study where they looked at Lifecourse disadvantage. They took 20,000 adults in the Molisani region, and they looked at people on the vertical axis is cumulative risk of atrial fibrillation admission, so the chances of getting admitted with AFib. Those who had low Lifecourse disadvantage from childhood up through adulthood had a significantly lower risk of getting admitted than those with very high Lifecourse disadvantage. So saying it opposite, which is if you have very high Lifecourse disadvantage, you're more likely to get admitted with atrial fibrillation. And about a 57% increased risk if you do a multivariable analysis. What was fascinating and gives us a little bit of a window into opportunities to make a difference is those who started out with high Lifecourse disadvantage, okay, their risk of AFib was halved if they attained education. So, that's pretty powerful. And it suggests that you're not just, your childhood circumstances. Now I'm going to turn to geography and rurality, and this is a topic that I really love to talk about. I don't know if you know this about me, Edwin. I grew up on a sheep farm outside Eugene, Oregon, and this is the barn where we, sheared the sheep. This is the Long Tom River, and we used to move irrigation pipes, et cetera. Anyhow, little known fact, nobody's ever guessed it in my entire existence. Anyhow, so I think rurality, this is an area where I think we as Americans really can come together, because if you're in rural America, it's pretty dire in terms of your health outcomes for a variety of reasons. part of it is just broadband access. You know, people in rural America, many of them, you know, some of them live in dead zones. Many of them live in broadband deserts and a care desert. Some people have a broadband desert only. Some people aren't categorized and not broadband. But look at how many people both don't have broadband and don't have care. Well, we were talking about this last night. You know, if you're 6 hours north, rather than driving 6 hours to find out you can't get an ablation, a lot of this can happen by telemedicine and you know, appropriate screening, which is a better utilization of the healthcare system and frankly more patient focused. So we do know that there's significant variation. This was just published this year in JAHA, where we looked at the initiation, various systemic care factors. This is a systematic review of 14 articles. And we know that compared to their urban counterparts, individuals in rural America were had a lower initiation of DOACs versus warfarin, which is sort of paradoxical because you think of the monitoring that needs to happen with warfarin, go figure. They also were more likely to have stroke as their initial manifestation of atrial fibrillation. They are more likely to present in an ambulatory care setting for AFib, and they're probably less likely to present in an ambulatory care setting, and they're less likely to get hospitalized. And if you conversely, those who grew up in rural America or who live in rural America are more likely to present to the ED for AFib care and more likely to have in-hospital mortality. So significant inequities by urban versus rural. And part of this also has to do with access. And, you know, this is older data, but we can appreciate, luckily Minnesota is in the blue and adopted and implemented Medicaid. But you look at the states who did not adopt Medicaid, they're much more likely to be in rural county, have a high proportion of rural residents. And this is deeply concerning and obviously is going to get much worse in the next year or two. So what can we do about, you know, people who are in, or patients who are in more remote areas? This is a randomized study that was published in Nature Medicine. I had nothing to do with it. It's a cluster randomized controlled trial. What they did was they did telemedicine-based integrated treatment of AFib in Chinese village clinics. And these village doctors aren't MDs the way we think of them. They're really more like community health workers, but highly trained community health workers. And they implemented integrated care pathway to avoid stroke with anticoagulation, treat the symptoms, and manage cardiovascular comorbidities. And so what were the outcomes? The primary outcome was CVD deaths, all strokes, heart failure, ACS, and hospitalization for AFib. And those who were randomized had a lower 6.2 versus 9.6% per year. The hazard ratio was 0.64 over 36 months. So the intervention made a difference. And I think this is something where it can potentially be useful for people in more rural communities. I'm going to now turn my attention to race and ethnicity. This is single center data from Pittsburgh Medical Center that looked at black and white differences. And I show this study because they looked at a variety of outcomes. And you can appreciate individuals who are black with atrial fibrillation had a 90% higher risk of stroke. This is, one would be, you know, neutral. And so a 90% higher risk of stroke, a 86% higher risk of heart failure hospitalization, a 39% higher risk of all-cause mortality. And they received 50% less likely to receive ablation. And, you know, that probably is pretty similar across the country. When we look at atrial fibrillation, part of the issues is that a lot of studies don't even report race data. Only a third of trials reported comprehensive race information. This is a study that was published just in 2025, very clever study where they tried to report what's the proportion of trial participants versus the participants in the disease population, right? So they're really trying to factor in, I didn't go into this, but for reasons that are not entirely clear, individuals of African ancestry are less likely to get atrial fibrillation than their European counterparts. They have worse outcomes if they have atrial fibrillation, but they're less likely to get it. So they factored in what is the relative prevalence in the population or the disease population versus their trial participation. And basically what they found were men were overrepresented, women were underrepresented in clinical trial populations. These are people with atrial fibrillation clinical trials. White participants were well represented versus Black participants, and Hispanic participants were markedly underrepresented. And it hasn't changed over time. Now, I admit, we talked about this a little bit at dinner. I'm not a clinical trialist, and I acknowledge that there are real complexities to doing clinical trials in diverse populations. And what I would say, one of the presidents of the American Heart Association was a first nurse, and I think one of the first women to be president of the American Heart Association back in the 80s, a woman named Martha Hill. And she did hypertension research in inner city Baltimore. And one of the things she told me when I was like a young pup, I think I was a fellow or something, she said, look at, we have to remember African Americans are not hard to reach. They're hardly reached, right? So that puts the locus of responsibility not on the patient, but how do we design our clinical trials? How do we design our outreach? How do we design our clinical trial research teams to look more like our patient population so we have an easier time recruiting diverse patients? And interestingly enough, I mean, this is obviously a highly moving target for people who do NIH trials. Obviously, many of us have gone through and have been forced to purge our biosketches of anything having to do with health inequities. I had to purge my 3 national diversity awards because I guess that's a badge of shame or something, or wokeness or whatever. So let's not talk about that. Let's talk about something that I think we all agree on, which is that everybody needs to be reached that potentially has a disease. And how do we design our trials so that the population of people that we reach looks like, in our clinical trials, looks like the population that's has the underlying problem. And the NIH is still collecting race data, right? So far. We're still collecting gender data. And so I think this is something that it really is incumbent on all of us, because if you're developing guidelines, what do we develop our guidelines on? If anybody's been on a guideline, you develop it based on randomized controlled trials. That's the coin of the realm. And so we need to have the randomized data really reflect the underlying patient population. And we can talk more about this in the discussion. So I was involved with this recommendation, not surprisingly. Not randomized data, okay, but we think that patients with AFib, regardless of sex and gender diversity, race and ethnicity, or adverse social determinants of health, should be equitably offered guideline-directed stroke risk reduction therapies, as well as rate or rhythm control strategies, and lifestyle and risk factor management is indicated to improve quality of life and prevent adverse outcomes. And we need to do a better job recruiting them into our clinical trials. Okay, so what can we do as clinicians? First, we need to diversify our training programs, practices, and research teams. If you really want to reach, quote unquote, hard to reach people, you need to have your team look like the patient populations you're trying to recruit because of a long history of medical mistrust. We need to use multidisciplinary teams and community health workers. We need to advocate for policy changes, and we need to support research to establish evidence-based implementation. We know a lot of the problems. We have less randomized data to say what are the solutions. I'm fond of saying that if I had to do it over again, I wouldn't be a lowly epidemiologist. I'd become an implementation scientist and really figure out how do we take our guidelines and decrease the 17-year gap between the evidence base of a recommendation and when it's actually implemented widely in the population. 17 years. Long lag of people not receiving evidence-based care. So I would ask, are we all practicing primordial, primary, and secondary prevention? Do we have comprehensive risk factor management? And, frankly, the American health system is in the red zone. I gather from talking to people last night that, given the complexities of 20, 30-minute visits, that we're probably in the moderate zone. I think all of us can do better. And some of this, it's a team sport, right? If you're an electrophysiologist, how do you write the letter back to the referring to say handoff, right? And I'm not going to talk to you just about anticoagulation or their ablation. We're also going to talk about all of the important secondary prevention measures that we need to be implementing. Now, I haven't looked at this in the last month or two, but the last time I gave this talk, CMS still had concerns about health equity. I suspect that this is going to go away. But with the last admission, health equity and a commitment to health equity was going to be a payment determination in 2025, screening for social drivers of health in 2026, and screen positive rates, dealing with the data from it was 2026. So CMS is proposing to remove the measure from, and we'll just leave it at that. So far, the Joint Commission still believes in health equity, although, again, this is a rapidly moving area. They recommend designating equity champions, assessing social needs and social drivers of health, stratifying key quality and safety data, developing a written action plan, monitoring effectiveness, and annual report. So, Edwin and I trained at a very, very diverse urban population. It's the largest safety net hospital in New England. And when the Lown does its report, it typically is either the most racially inclusive hospital in the country or in the top 5. Very, very fascinating and wonderful population. I really consider it an honor to work there. So we looked at our data. You're never going to meet a group of providers who care more about health equity. And we had gaps in care when we looked by race. One of the biggest gaps actually were maternal and child health. And so we developed an action plan to narrow the time to C-section, to change outcomes. And so I would urge all of us, I think all of us, it's everybody else who has bad outcomes, and we're fine, we're good, but you got to look at the data and really understand what is your data, not just some theoretical data. So what are our research priorities? We know, this is a slide I borrowed from Kevin Volpe, and he's one of the world's leading health behavior economists, and he's in charge of the food as medicine for the American Heart Association. We know that globally, the United States is 46 in life expectancy, and of course, our healthcare spending is out here. This was a slide from 2023, so here we are, like twice the spending of other countries, right? And we have worse outcomes. So, whatever. We have marked inequities. And these inequities are amplified by social drivers of health across the life course, whether it's socioeconomic status, health literacy, which I didn't have time to talk about, race, ethnicity, rural, et cetera. And it happens at the primordial and primary risk factor prevention, at the diagnosis and trust level, symptom control, shared decision-making, goal-directed medical therapies, and randomized controlled trial access, all the way out to outcomes. And this is something that we published as a report from the National Heart, Lung, and Blood Institute in the prior administration when we were trying to define the research agenda to make a difference in atrial fibrillation. So in summary, for primary preventions, patients at increased risk of atrial fibrillation, and I would say my father had AFib. What I'm trying to do, there's this thing called compression of morbidity. Like, we're all going to fall apart at some point. We're all going to die. That's so what I want to do is I want to have a really, really, really healthy life and have a spectacularly terrible last month of my life, right? That's great. That's compression of morbidity. So what we want to do is we want to either postpone or prevent the onset of atrial fibrillation. And so we need to manage lifestyle and risk factor management, and that's a class 1 recommendation. For a secondary prevention, class 1, most of this is randomized: obesity, exercise, alcohol limitations, or abstinence. Not randomized: smoking cessation, hypertension treatment. And level of recommendation A, comprehensive care for lifestyle and risk factor management. In terms of social determinants, the AFib guidelines and JCAHO focus on health equity. We need to diversify our recruitment and retention of diverse patients in observational and pragmatic studies by gender, race, ethnicity, income, and education. We need to diversify our settings, and I know that you all are doing some of your clinical trial enrollment away from the mothership, out more in the community and rural areas. We need to develop innovative methods to analyze multiple intersectional identities so people aren't just of African ancestry or aren't just low socioeconomic. I mean, all these things can interact, et cetera. And we need to think about the cumulative disadvantage across the life course. And most importantly, we really need to have, I don't think we want to have more studies where we describe the problem. We really need to have pragmatic studies to test multi-level strategies to mitigate social drivers of health and AF diagnosis, management, and outcomes. And with that, I am done with my talk. Thank you so much for your attention.
Thank you, Emelia, for a wonderful overview of AF epidemiology and some of the social determinants of health here. What would you say to someone who says, I meet AF patients basically every day that I'm in the clinic. Some of my patients have AF, and I, like most of my colleagues, try to talk to them about their weight, their sleep apnea, optimizing all their risk factors. But many patients are not interested. You start talking about their weight, and even though now we have medical options where people can lose 10% or more of their weight and such, they say, Doc, I came here and I want an ablation or want an antiarrhythmic, and I'm not very interested in you talking to me that my BMI is. Do you have any suggestions as to what we as providers can do? And that's actually a lot of patients.
Yeah, no, I get that. Well, first of all, you can do a procedure, but the likelihood of its success is dramatically improved by attending to these other issues, particularly weight, as you know, and alcohol. And so I would say, how do we form a partnership here? And so I stopped doing clinical care back in 2022 because I hadn't been paid for it for 4 years, and I kind of was tired of working 100 hours a week. And so I stopped doing clinical care. And also, I didn't want to do a Biden or a Ginsburg. I hope I didn't offend anybody. I wanted to go out on top. I was 65. I hadn't had any terrible outcomes. I wanted to stop while I was ahead. So, when I did manage my patients, you can't take on everything, right? And so you have to figure out what is the thing that makes sense to them, okay? And it may be smoking cessation. That's a trip to Disney, basically, if you stop smoking, right? Or you have to figure out what they're motivated to change and then really go after that. Most people, if you talk about, okay, this may be the difference between you getting to a grandchild's wedding or not, right? If you start talking about the things that are important to them, and frankly, forget their AFib, they need to lose weight for also, their heart failure, right? They need to stop smoking for their heart attack, their stroke, et cetera. And so I think one of the things that we haven't done a great job with is really, and I know your prevention colleagues who we met with last night really are thinking about this, is we need to stop kind of just saying, okay, this is about your AFib, this is about your MI, this is about your stroke, this is about your dementia. And that's what they're trying to do with the prevent equation, is really say, a lot of these things come together. I will tell you, and it's funny, I just had a conversation with Don Lloyd-Jones, who was instrumental in the prevent equation and past president of the American Heart Association. He moved to BU to lead Framingham, and we proposed a grant. And in it, we had, I said, well, let's use the prevent to prevent, to come up with the risk of AFib. And he said, actually, prevent doesn't work so well for AFib. You get to use your score, the charge, So, but a lot of the factors are the same. And, you just want to kind of, hook onto one and figure out what motivates them. We don't do a great job motivational interviewing. We do a great job telling people what to do. That doesn't work. You have to figure out what they want to do and tap into their intrinsic motivation.
Thank you. I'm going to check out the Long Tom River when I get home tonight to find out where that is. I wonder, once the patient shows up in your office with AFib, it's a little late in the game, it seems to me. And I'm wondering what you think about trying to identify patients at risk beyond the the risk factors you outlined. For example, a 12-lead EKG. If you
Oh, wow,
have
wow.
any
I love that.
any perspective on
Yeah.
using that as a
Yeah.
guiding patients.
Yeah, so we've published on this, and the Mayo Group has obviously published extensively on this, is that for any given imaging or test that we do, there is an infinite more amount of data that we cannot perceive. And the people, particularly younger people in this room, are going to be using AI every single day. Probably, I think one of the most useful is going to be for risk stratification. So I'm collaborating with a group in Mesa and Framingham looking at AI analyses of the CT scan. And in fact, you can predict, done for CAC or whatever, you can predict atrial fibrillation. Probably they're picking up on epicardial fat, if I had to guess, on markers that have nothing to do with coronary artery calcium. Your question is, what about the ECG? And we've published, and Mayo's published, and a whole bunch of other people have published that you can use AI to come up with subtle, that we can't really see. One of the things that's interesting, so, I've done a lot of work both in genetics and clinical risk prediction. You can get pretty far just with clinical risk factors, right? And with genetics, you can't really alter at this point, you can't really alter your genetics, but it can help you risk stratify. So that was that lifetime risk is, there is a third of, people that polygenic risk is quite high. Those might be people that you really try to prevent the atrial fibrillation. The other thing that I would say is that I agree with you to a certain extent. After somebody has AFib, the cow's out of the barn or whatever, to use the rural analogy. And if you're doing an ablation, it's going to be more effective if you address the risk factors. And also all the other things that are going to happen to them. If they smoke, they're going to be less likely to have a heart attack or stroke and dementia, right? And so I think we need to be thinking about this kind of life course. How do we prevent a lot of different bad outcomes, not just the AFib? Thank you. Thank you for the question.
Are there any online questions? All right, here you go, Michael.
Well, thank you for coming out. This is kind of a long, meandering question, so I apologize. But
I've been giving long, meandering answers, so I'm really glad that you're doing a long, meandering question. Makes me feel better.
On one of the earlier slides on the AFib risk and then polygenetic risk scores, especially in the high-risk cohort, who has also, from polygenetic as well as clinical risk factors, had everything. It struck me that one, it was a sigmoidal curve, not linear per se as people aged. And second, it had basically an asymptote at 50. And certainly there's some competing risks as people get up to 95. But has anyone looked at why are these genetically high risk, clinically high risk people not getting AFib? Kind of flipping the question on the head and seeing that negative space.
Yeah, that's a really important. So essentially, it potentially is the genetics of lower risk, essentially. And I think a lot of it has to do with lifestyle. Some of it has to do with socioeconomic status, and clearly they interact. Why does it tap out at 50? There are some people, it's kind of like my grandmother smoked 2 packs of Bench and Hedges a day and she lived into her 90s. I mean, like there's some people who, I don't smoke, but there's some people who just whatever you throw at them, they're kind of impervious to getting bad things happen to them, right? And, why is that? Probably strong genetics and also, luck and who knows what. I don't think we really understand enough about what are the prophylactic, what are the preventive factors that really help people so that they don't get bad outcomes. Important question, although on some level, do you really want to give somebody the message, oh, you're scot-free from AFib? Because even if they're scot-free from AFib, they may not be free from developing heart failure, et cetera, and the cumulative burden. We know, I mean, let's just take smoking, which is the stuff that I know. I had a tobacco grant for 10 years. That was ran the training grant on, and we know if you quit smoking when you're in your 30s, you live 10 years longer. That's unbelievable. 10 years. I mean, I'm sorry. No ablation, no medication we give is better than the 10 years of quitting smoking at the age of 30. Like, we don't have anything that powerful. And so I think, you know, it's important to think about, is there something, and maybe there's a genetic insight that will give us something to target in terms of drug therapies. Thank you. Thank you for the question. Important, provocative question.
If there's no additional
Great. Thank you all very much for your attention.